them.
Yeah. Thank you. Okay. Okay. Everybody got your eyeballs in?
Yep.
Okay. Shane, you want to lead off?
Sure. So looks like a sharp tooth lining assist,
Shark tooth lining, so give me two cysts that can do that.
dermal assist, and steatocystoma.
And which one do you think this is?
I mean, there's some sebaceous glands, but no like actual full, like terminal hair follicle.
Yeah, so the only adnexal structure you see is sebaceous glands, so that's good for steatocystoma. The other thing that helps is dermoid cyst usually has keratin in it. Steatocystoma has oil and vellus hairs. So, you know, the contents help, and, you know, grossly, the steatocystomas collapse, whereas the dermoid cysts tend to remain round. So, see how that one was kind of flattened, squashed? That's typical for a steatocystoma. Okay. Dan, what do you think?
So there's a lot of pigment in the dermis.
Yep.
I'm thinking probably a blue nevus.
Yeah. So, you know, either blue nevus or tattoo would be the two things that it could be. For a blue nevus, you'd like to see that it has at least some of its own compact stroma. And I'm not sure that it has that much ropey collagen here. Given the absence of ropey collagen, it might be good to do extra evaluation just to be 100% sure this isn't dendritic melanoma, you know, uveal melanoma of skin. So for any of the fellows, if you had only one stain to pick, so GNAC would probably be your background, but so then BAP. It's usually BAP on top of GNAC for these. So if you don't have either of those, MIB looking for an elevated proliferative fraction would probably be good. But this is one where right now at some centers you have something that looks kind of like a blue nevus but doesn't have its own stroma. They're getting a BAP. If the BAP one is lost, that's, you know, potentially bad news, because that's what uveal melanoma in the iris and uveal-like melanoma in skin look like. Okay. James, what do you see?
So it's like a big, like, proliferation of, like, fibroblasts looking cells. I mean, it could be just NF as well.
So it's certainly loose and kind of mixoid. What do you think on higher power for NF?
No, I guess if you haven't stopped asking me.
Or yes.
Well, that's misleading. So
Sorry, it wasn't meant as a trick.
is it still NF?
Well, you tell me what they're.
That's what I think it is. If it's
Okay, so what features are we looking at?
Dolphins.
Yeah,
Or not,
like
if it's wrong. Well, I'm just confused by your
I'm
cases.
sorry. Just looking at the higher power features, it was not meant to be tricky. So we see mast cells, and we have sinusoidal kind of S-shaped nuclei, which are good for NF, so that's fine.
So you have a busy dermis, sort of locally. Looks like there's some collagen trapping. But, kind of looks like gel film.
Yeah, exactly. So you have multinucleated giant cell, all of this gray squiggly stuff is gel foam, so you're looking at a biopsy site, basically. You know, there's no tumor, there's scar on the two sides, there is granulomatous and lymphoid inflammation, and there's gel foam in the center. Something you definitely would see, so you know you should be able to recognize it.
They got large, blue balls in the dermis.
And are they all happy, or are some of them?
So they've got some central necrosis.
Yeah, so some comedo-like necrosis.
I mean, when you think about epithelioid sarcoma with the areas of necrosis.
So it's definitely something that epithelioid sarc can do. We see lots of mites, lots of mitoses.
Yeah, so something growing, proliferating. Let's see, so what kind of cells are these? Kind of large open vesicular nuclei. I mean, could it be a melanoma? Perhaps.
Yeah, so you're probably going to do immunostains to confirm. I don't see good rhabdoid morphology in these, but certainly it's metastatic something that's kind of spindled in epithelioid. Staining for epithelioid sarc, INI, loss of INI staining, co-expression of keratin and bimentin would certainly be reasonable for this. This one ends up bimentin positive, keratin negative, and is also SOX10 positive.
So is that like a melanocytic?
Yeah. So it's pretty good for melanoma. So, just big nodular met.
So it looks like you have like a sparse perivascular superficial infiltrate.
Yeah. Is your stratum corneum uniform? Or is it basket weave above and compact below?
Basket weave above and compact below.
So tinea would be the first thing you'd want to rule out. So, and where would you look? Would you look in the basket weave above or the compact below?
Compact? The other way around.
Yeah. No, the compact. You're right. The compact below. The basket weave is the old normal stuff. So you look in the compact below, and if there are little clear circles like that or a little tinea like that, then you got it. Okay.
Looks like we're here.
Yep.
So think about things like accessory tragus. Just
Things like
anything else
accessory
there.
tragus. Does the cartilage look entirely happy?
That doesn't look too great right there.
Why is it kind of split in half? And then,
It's a pseudocyst.
yeah, and if that's the normal thickness, then you're only seeing half of the cartilage there, and it's gone pink. And so you are correct. Pseudocyst of the auricle.
Looks like we're on the scalp.
Looks for on the scalp. Everybody's favorite.
I don't see much of an infiltrate. It looks like the hair follicles are kind of doubles together. Maybe some miniaturization of a few of them.
So there is some asynchronous miniaturization that can go with alopecia areata, or it can go with pattern alopecia. What percentage of the male population has pattern alopecia?
50.
What percentage of the female population? 50. Exactly. So background pattern is half of everybody. So then the question is there anything else going on? And so let's start looking at the hairs. what kind of hair is this with all those dead reds in it?
Is that telogen?
Or so a hair that has lots of apoptotic dying keratinocytes. Would that be A, growing, B, stable, C, shrinking?
Shrinking.
Correct, which is catagen.
Catagen. Okay.
Yeah. So catagen, all these dead reds means it's in an active state of shrink, right? So that is a catagen hair. What's this one?
Catagen.
So pretty much everywhere I look, I see catagen hairs. What will give you catagen hairs all over the place? Name 3 things that will give you catagen hairs.
It's like just telogen effluvium because you're.
Telogen effluvium, by the time you lose, they're way past catagen. They're already in telogen.
I'm not sure.
So, anyone want to jump in? So, alopecia areata, trichotil, and what looks just like AA, syphilis. Okay, so multiple catagen hairs, alopecia areata, its look-alike syphilis, and trichotil. So then you start looking at other features. Do you have any pigment in fibrous tract remnants? Do you have any peribulbar infiltrate? Do you have weird shaped remnants of keratin in the follicles?
Yes.
That's a yes. And then sometimes you'll see strange fractured hair shafts in trichotil. The pigment casts in the follicular channels, that you can see in any of the 3. So the pigment casts don't help you.
Is that a fractured hair shaft? It's a little bit south.
Down here?
Yeah.
Yeah, it's more just keratin and pigment cast.
Okay.
But, you know,
Blood, right, I guess.
yeah, hamburger sign, you know, is where the hair shaft is broken in 2, so it looks like hamburger bun with debris in the middle, which is the patty, and you can get hot dog signs and all kinds of things like that in trichotil. But just all that weird keratin goes with trichotillomania too. You tend not to see it in the other 2.
The difference between the pigment cast and trichomalacia, is that? I've heard of what just the term.
What
difference?
distinguishes?
Yeah.
Pigment cast is just pigment. Trichomalacia is a softened gelatinous hair, so you can clearly make out that it's a hair fiber.
Okay.
Hair fiber that's gone soft, whereas pretty much everything we're seeing here is just keratin, you know, inner root sheath keratin, and pigment casts. And the pigment casts within the hair channel you can see in any of the 3, trichotil, AA, syphilis. Pigment down in the fibrous tract, so not in the hair canal, but in the fibrous tract, that's alopecia areata or syphilis. In the canal can be alopecia areata, syphilis, or trichotil. Normal inner root sheath keratin is kind of dull pink like this. The really bright red keratin is characteristic for trichotillomania.
Looks like there's cells in the dermis. Some like it looks like the epidermis is a little ominous, maybe, or thickened.
Yeah, so it's definitely thickened. There's compact hyperkeratosis. There is beaded irregular hypergranulosis. There's PEH of hair follicles. Is the basal layer intact, or is it having a bad day?
It's having a bad day. Sure.
So do you see an intact basal layer shot full of holes, or is the basal layer gone and what you're seeing is squamous layers shot full of holes?
I think it's more squamous layers.
More squamous. So you have squamatization and PEH. Any thoughts?
Sure.
So when you have a band-like infiltrate and loss of your basal layer with squamatization, You're looking at what kind of tissue reaction.
Yeah, interface.
Yeah, and more vacuolar or more lichenoid?
More lichenoid.
More lichenoid. So what kind of things can give you lichenoid dermatitis?
Like parasitoids or...
So pityriasis lichenoides is usually more vacuolar, interface, lymph in every hole. So the lichenoid things are often
Lichen
things that
planus.
start with lichen.
Yeah, lichen planus.
Yeah, so lichen planus, lichenoid drug, lichenoid GVH, lichenoid regression of melanoma, acral lupus. So which ones tend to have PEH like this? PEH of the follicle. Give me 2 out of that list of lichenoid things that tend to have PEH of the follicle. Anyone want to jump in? Hypertrophic LP and lupus. Those are the 2. So when you see hypertrophic lichenoid like that, follicular PEH with lichenoid dermatitis, it's hypertrophic lichenoid dermatitis. It's either going to be hypertrophic LP or hypertrophic LE. And what's your golden test?
Narrowband. Differentiate solidly between.
Well, narrowband might actually do it, but DIF might be kinder and gentler to the patient. Yes, as opposed to trial by fire.
So this looks like a tonsil or a lymph node.
Looks like tonsil or lymph node, except that it's neither. So, it does sort of look like node. But this...
You got a lot of reactive germinal centers.
Yeah, you have lots of reactive germinal centers, and if you look higher, there are lots of EOs in there, too.
Just a rip-roaring ALH or Kimura if it was in a lymph node.
Yeah, exactly. So, the difference between ALHE is angiolymphoid hyperplasia with eosinophilia is an arterious venous malformation that has a secondary lymphoid infiltrate, whereas chimeras is a primary benign lymphoproliferative that gets some vascular. And this one, honestly, at scan could be either one. You don't see that big muscular vessel in the center characteristic for ALHE.
That really looks like a lymph node.
Yeah, it does look like a lymph
It's got a capsule
node.
and sinuses.
It does. So let's see if we have...
What's that?
Ah, there we go. Okay, so what if there are no EOs there? Let's change track.
You've got a met of badness to your lymph node.
Yeah, then you got something badness, and what kind of badness?
So there's a lot of extravasated red cells, so you worry about metastatic angiosperm.
Yeah, which is probably what this is. There you go. Okay, let's see.
Well, it looks like it might be an excision, and there's some pigment in there.
And what kind of pigment, probably?
From here, it looks more like hemosiderin.
Yeah, which would mean it probably was Montcells,
Oh, okay. Yeah, and
right?
there's
Because
some
it's kind of
scar.
sitting in a scar. And then, so this is probably a re-excision specimen, right? Actinically damaged skin, Montcells, and then...
Maybe some morphiform basal down there.
Yeah, exactly. That's what it looks like. That's the traction space. See, what does that say? Oh, so the story here was the original biopsy was read as superficial multifocal, BCC, and that's certainly present. Unfortunately, that doesn't always predict what's underneath. In fact, that's it.
I'm not seeing a whole lot.
So not seeing a whole lot. So what if this were a scalp biopsy?
I would be concerned that the patient has an alopecia.
Since there's not a whole lot, including not a whole lot of hair.
And then there might be some kind of scarred fibrous tracts.
So when you look at the fibrous tract, are they particularly wide?
No, they're narrow.
How about when you get to the top?
Much wider. Maybe wedge-shaped.
Much wider, maybe even wedgy. Give me two things that could do that.
LPP and, well, I guess FFA is the same thing, essentially.
So that counts. I asked for two, right? So frontal fibrosing and lichen planopilaris. And how about another one? What if instead of being lymphoid, it's suppurative that hits the infundibulum?
Folliculitis decalvans.
Folliculitis decalvans. Those would be the ones that give you superficial wedges like that.
You have a papule of some sort.
Papule of some sort, and does it look like skin or more like mucosa?
It looks like mucosa.
Yeah, it looks like mucosa. And does that look like a submucosa? Or is it bundled like a dermis?
Bundle like a drug.
So we got a disconnect there, right? Because the lining certainly looks like mucosa, so somebody's lying, right? Either the dermis is a fibroma or the mucosa is lying. Which do you think it is?
Maybe the first one.
Yeah. So this is a benign submucosal fibroma. Because a normal submucosa doesn't have any bundled collagen at all.
So wide excision. There's something in deep dermis and
Yeah, so the top looks scar-like. Either they've been there before, or since this is scalp, what else would be scar-like? Hairless patch on the scalp from birth.
so that like a gold.
Yeah, or like an aplasia cutis congenita. And then, so we got something that's under a scar or an aplasia cutis congenita.
So like a vascular.
They look kind of vascular, except that the cells are wrapping around collagen bundles. So what has vascular-like channels and then loves to wrap around collagen?
Like a
Yeah, you got it. Rudimentary meningocele. That's exactly right. So meningothelial cells, their job is to wrap things, coat them, right? So they make these vascular-like channels, but then they wrap around collagen balls. And that, very commonly would present with aplasia cutis. So, good.
Yeah, I'm not seeing a lot of excitement. There's a kind of a papillomatous look of the epidermis.
Yeah, and is that a normal corneum?
It looks a bit extra.
Looks a bit extra. Is it compact?
No.
Is it parakeratotic?
I can't tell if that's if that's new to a crust there, or if there's a little bit of focal para there, but
Not so evident, though, right? And what would you call it when pieces of corneum flake off like that? What would that be clinically?
furfuraceous-iform.
It would be a furfuraceous scale. Now, why are you jumping in right to furfuraceous? How do you know that's not any other kind of scale?
Because it's the only kind that rises up instead of falls down.
And it's not parakeratotic, right?
Sure, that's not helpful.
So it's the only one that floats in the air. It's not a heavy parakeratotic compact scale, which all other scale is histologically. This is the only scale that's made of loose keratin bits and is characteristic of?
TV.
Yeah. So, we haven't even gone to high power, and already it's tinea versicolor. And so then if you want to look higher, another thing that is characteristic for TV is that the hyphae are gray in H&E, whereas neither tinea nor candida pick up stain significantly. TV is, very, very gray, and you see the ZD there and the meatballs here. Does it grow on sabrodes?
No, I don't think so. You have to have the oil, right?
Yeah, so you have to, what would go with ZD and meatballs?
No.
Olive oil to make it grow. Correct.
Squamous, I was kind of worried about a squame.
Yeah, it certainly looks, those are ugly cells, high nuclear cytoplasmic ratio coming off the epidermis. It doesn't palisade, so I would say squame. All kinds of writing on here. What do they say? Squame is what it amounts to.
Shave biopsies and reticular acanthosis. Think about a reticular seb. There's no
Yeah,
atypia.
like a reticulated seb. There's no atypia. You have horn cysts. You have keratinocytes that are about the size of acrosyringeal keratinocytes, about half the size those of normal keratinocytes. But then you have all this pigment incontinence. And it's outlining pink chunks. So what would that be?
That's probably some macular amyloid.
Some amyloid. And it can be, when it's surrounded by pigment, it's epidermally derived. That can be macular amyloid, it can be lichen amyloid, or it can be neoplasm-associated amyloid. What do you think it is in this case?
Probably the keratinocyte.
Yeah, and probably just because of the seb. You see it under sebs, you see it under Bowens, you see it under basals, basal cells, all kinds of things, where you can have neoplasm associated with amyloid. So, the big thing is it does not mean systemic amyloidosis.
Cystic proliferation.
Cystic proliferation.
So it gets filled with just kind of gray amorphous.
Kind of gray amorphous. And you go towards the center. Does it have any other?
Kind of feathery.
Kind of feathery, making you think.
Gout.
Gout. So why is most of it so amorphous instead of feathery? Fixed in formalin. To get feathery throughout, you got to fix it in alcohol. And as we learned after Hurricane Katrina, when there is no formalin to be had, wild turkey works great. That's what all we at Geisinger we got, because there was no medical center standing in New Orleans except for Ochsner, and they didn't have Dermpath. And Geisinger was the sister clinic, so we read all the path after the hurricane. It all came in bottles and jars of wild turkey. We're great. You could do immuno. You could do everything on it. I've never seen better histology. And the cocktails afterwards were great. Okay.
I feel like I'm seeing like the outside of maybe like a collapsed cyst or.
Yeah, it looks almost like collapsed cyst, but it's very fibrous wall. So you start thinking of things like what would be a fibrous walled cyst. So some of it could just be like a ganglion.
Oh.
You do have some vessels in there, though. You got some vascular proliferation there. This thing looks like it was a traumatized vessel. So, like a traumatic AVM would also be something you'd think of. Let's see what history is. They're saying essentially ganglion, metastatic synovial cyst. They follow trauma, which is why you've got the AVM changes. So you actually have both there. You've got a traumatic AVM and you've got the ganglion-like changes that are the metaplastic synovial cyst.
Let's see, proliferation in the dermis. Pretty dense. I'm not sure this is like one of those spindles, so like slamming up against the dermis, or.
So, is it spindled here or more solid areas?
There's some solid areas there.
Blue or pink?
Blue, so maybe like a.
Retraction space and spiky.
Yeah, it's maybe like an infiltrated basal synovium.
Yeah, like an infiltrated BCC. Very good.
So you got a lot of multinucleate cells.
A lot of multinucleate cells. Anything in them?
Looks like there's keratin. It's probably
Yeah.
just a keratin going on.
Yeah, I mean, that's really what it looks like, is multinucleate, randomly distributed nuclei, so like foreign body giant cell. And, yeah, ruptured cyst is what they're saying, which makes sense. Giant cells and keratin.
So there's definitely some separation of the epidermis. Looks real, so it could be in the vesicular bullous category versus secondary.
Yep.
And it has kind of an acute look.
So it definitely has an acute look, which would raise the possibility of
Like fixed drug.
so like fixed drug or EM. And then you'd look at the infiltrate. So it could be impetiginized, given the polys, or fixed drug or EM, which would be more likely to have neutrophils.
Yeah.
Neutrophils, probably in fixed drug. EM tends to be only lymphs, so either EOs or newts would go more for fixed drug. I don't see any deep pigment, though. Looks like there's some trauma or necrosis of the vessels.
What about look at bullous LCD? How it can mimic immunobullous sometimes?
Absolutely. I don't see a lot of karyarexis around most of the vessels, maybe some around that central there, but that's more between the collagen than around the vessel. When I look at the vessels, they're dead. They're polys. I don't see a ton of karyarexis. I do see one or two EOs. So, it's kind of EM-ish, but with newts and a few EOs. Fixed drug would probably go to the top of my list, but I'd want clinical, because immunobullous, vasculitis, all of those things are reasonable thoughts. And the history was they had pulled a tick off. So, it's another mimic that in this case was arthropod. We didn't see any mouth parts. There were lots of thrombi, which certainly will go with it. The bulla is a little bit of a red herring. That would be unusual.
So this is a big, I'm sorry.
Lots of bullous arthropod, but not usually bullous tick. Okay, I'm sorry, go ahead.
Anyway, this is a basaloid neoplasm.
Basaloid neoplasm.
So basal cell. From up here, I'd even make sure it's not Merkel.
Yep.
Because they're a little smudgy.
The nuclei are a little smudgy as opposed to smudgel. The adenoid appearance
Goes more with basal.
goes more with basal. Agree. But, when the time to get immunostains is when you wonder if you should have, so, getting Merkel markers would not be wrong.
So that looks like neutrophils in the left shoulder.
Yeah, and anything within it.
Yeah, maybe some bacteria there.
Yeah. So some cocci, some staph. So probably
Some sort of abscess or not necessarily abscess.
yeah, and it's sitting right up subcorneal. So probably impetigo. With all that staph there. history, they're saying AGEP. If that's AGEP, it's secondarily impetiginized because there are big staph colonies there.
There's loss of the next side. I don't see much fat.
Loss of adnexy, not seeing much fat.
So it's kind of squared off.
Kind of squared off. Thick collagen bundles, not a whole lot of space between the collagen bundles, but the elastic fibers are really prominent and red. That all goes with morphia. Correct.
What would you see on like radiation or dermatitis?
Radiation would be similar. You don't tend to get the red eosinophilic elastic fibers, and you don't tend to get the perivascular lymphoplasmacytic infiltrates that were present there. They weren't great big nodules, but they were there around the vessels. Also, you might see radiation fibroblasts. You might see vertical columns of radiation elastosis that looks blue. The elastic fibers in general tend to be blue rather than red, which they are in morphia. And did we talk about vascular ectasia? That would be the other thing. You know, that you may or may not have. So you'd look for all of those clues.
Accessory tragus.
Probably an accessory tragus. Looks like the world's smallest ear. Right?
Very small crunch. We have a interstitial sort of lymphocytic infiltrate. Think about interstitial GA or GA.
Yeah, I think that's a very good thought. Your question would be, you know, there are some giant cells in there. The question would be how many other histiocytes are in here. So in inflammatory interstitial GA, things that are related to that, like interstitial granulomatous dermatitis. I see occasional EOs. Both of those can do that. Arthropod, necrobiotic, or interstitial granulomatous arthropod would be another thing. The clinical history that went with it was granuloma annulare. Good.
A large cyst here. It's like a very thin walled.
Yep.
Something about a hydrocystoma.
Yeah, like a great big hydrocystoma.
Regular acanthosis. It's like there's para at the top.
So this pair on the top, irregular acanthosis. Tell me about the papillodermal collagen.
Vertically oriented.
Vertically oriented. So I see epidermal hyperplasia. I see vertically oriented collagen in the papillary dermis.
Yeah, it's like LSC.
Like LSC, but LSC is usually orthokeratotic. There's a little sponge here. So this is LSC superimposed on chronic dermatitis. There's a little serum up in the horn. It's a parakeratotic horn, whereas pure LSC has an orthokeratotic horn. There's significant spongiosis. So this is a very chronic spongiotic dermatitis that someone's just been scratching the crap out of. So there's LSC on top of it.
Thin little shape. First glance, just a little blue basal. It looks like a little basal cell.
Like a basal cell. So tell me about the margins.
Looks like the stroma is going to the margin.
Yeah, exactly. So you don't have to see tumor at margin. Stroma at margin counts. So normal papillary dermis would end about where the tip of the arrow is, and everything below it would be bundled collagen. This is all tumor stroma, all the way down. And that's going to an edge, so that counts as positive.
hyperplastic epidermis. Some. I don't think I see any pseudohornsis. Is there like acantholysis in there too?
So there are definitely pseudohornsis. There is. So if it were acantholysis, the cells would be round. Are they round or are they stretched out, hanging on with long, thin extensions?
More the latter.
More the latter. So it's more like just extreme spongiosis. And is everything spongiotic or just clones within it?
Just clones.
So do you know anything? So an inflamed clonal seb. When a clonal seb is pigmented, only the clone is pigmented. When it's inflamed, only the clone is inflamed. Because it's antigenically different from the rest of the skin.
So, I'm worried about something infectious. You've got some like pH, like there's sort of a little abscess within the epidermis
Yeah.
there.
So you have pH with pus, you have a little abscess
Yeah.
in the epidermis, so infectious would definitely be up there. Something post-surgical, a piece of a keratoacanthoma, there's certainly elastic trapping.
I almost looked in the other piece, like maybe there was like hair shaft in there.
Yeah, there's something that is refractile, right? So, whether that's foreign body or hair shaft, you would go on a bug hunt, you'd also want history. Let's see what we got here. We got elastic, we got newts. I'm seeing organisms jumping out at me. Let's get... And so, by history, it was an M. marinum infection. But your differential was good. And it's always about the differential, and then we can get history after.
So there's some orthokeratosis, and there's also a little bit of superficial perivascular infiltrate, and some of it seems to be tagging the DEJ, some limbs filling holes and percolating up into the epidermis. So I'd be a little worried and want to look closer for MF.
Yeah, you got some bundled, so you got some linguini type collagen or bundled collagen above the postcapillary venial, which would not be good. You'd look to see, I'd say the infiltrate's kind of both around top and bottom of the vessel, not so much a bare underbelly, but you might start worrying about MF, given that you have papillodermal fibrosis, it's a chronic process, hyperkeratosis, and you have some basilar tagging, lymphs in the epidermis without a whole lot of sponge. And I can't even read that. What does it say?
An exotrophic lymphocytic infiltrate.
In other words, they're not sure. But they were worried about MF.
Definitely hyperkeratotic. There's definitely AK in there.
It's definitely AK. You see an actinic horn, red with vertical blue, horn, budding. And then the question is there anything other than AK? Probably not. And the AK is acantholytic. Okay, very good.
So this is likely an excision of some sort.
Likely an excision of some sort. Where?
Scalp.
Where's the hair?
It's missing there.
And are all the hair follicles totally missing, or just terminal hair follicles missing?
Terminal hair follicles.
And instead, what do they look like? Lots of little bitty follicles all lined up. What would give you a patch of little bitty follicles like that on the scalp?
If you have like a pattern alopecia with like an miniaturization of the hood bark? Is that what you're going for?
Well, it's very localized, right, with
So
an
like
abrupt
a-
cutoff here.
Cutis
So, well, aplasia cutis, there'd be scar. There'd be no adnexal structures.
or- Okay.
But first off, how red is your collagen? Pretty red, pretty fine. So this is probably kid skin. So this is a kid on the scalp, and then he's got a hairless patch that's kind of broad.
Probably Nevus sebaceous.
Yeah, exactly. How old is this kid? Before or after puberty?
It's before. 'Cause
Before.
It's bubbly.
Because it's broad, it's bald, but it's not bumpy and it's not bubbly, right? So prepubertal nevus sebaceous.
It looks very warty.
Looks very warty. You got lots of coilocytes. You got columns of parakeratosis. The horn is compact, but looks like someone's taken a little round cookie cutter and cut little white holes out of it. That's a wart.
Dare I say TFI?
You might dare say TFI. The only thing wrong with TFI.
Never TFI.
Well, that's not true. This kind of area I would love for tumor follicular infundibulum. But the basaloid buds here, so what would give you pink strands, blue buds? And they anastomose.
Oh,
And they have eccrine-like ducts in the strands.
It's not pincus, it's like the other
Yeah,
Pincus.
pincus. So infundibulous cystic BCC radiates out from a central follicle, pincus anastomosis. So pincus tumor. So we've got a big ulcer, right? And then the question is, anything in the background causing it may have caused the ulcer. So let's look at the adjacent skin. You've got a lot of sclerosis there, right?
Maybe like just a stasis.
Like stasis, is that cannonball-like angioplasia, or is that bizarre-shaped large ectatic vessel?
Bizarre, large-shaped ectatic vessel.
And why are the fibroblasts so big and gray and stellate?
That is like a radiation.
Like radiation, so ulcerated radiation dermatitis. This is just off the midline of the back. What caused it? It's kind of a circle, midline of the back.
Besides radiation.
So, yeah, prolonged fluoroscopy. So, very good, David. So, prolonged fluoroscopy, they're looking at all different angles at your chest, but they all converge on one spot on your back, and it just burns a radiation hole in your back. And you'll see those people. You look at their back, and they've got this one round burn of radiation dermatitis right off center from the spine. They had a cath that took forever.
No shave. Looks like there's some pigment superficially. So I'm trying to tell this like pigment incontinence. Yeah, it looks more like pigment incontinence, I think.
Tell me about your epidermis.
It's pretty atrophic. It's been kind of like chewed on, so it could be like kind of a not burnt out, but there's been lichenoid.
Yeah, so it's a burnt out, almost flattened, but still sawtoothed. You've lost your basal layer. They're vacuoles, but they're all in squamous cells, not within basal cells. And you've got these pink globs surrounded by pigment.
Some Savat bodies.
Some Savat bodies. So this is a late stage of a lichenoid dermatitis. Tell me things that can cause a late stage of a lichenoid dermatitis.
Lichenoid GVH.
So lichenoid GVH. What else?
Lichenoid regression of melanoma.
Lichenoid regression of melanoma if it's broad on sun-damaged skin. What else?
Like an old ashy dermatosis, something like that.
An old ashy dermatosis, which is basically the same as lichen planus actinicus. What else?
Like a burnt out LP.
burnt out LP, burnt out lichenoid drug, burnt out benign lichenoid keratosis, basically your whole lichenoid list. Even lupus and dermatomyositis, could be in there. It's not hypertrophic lupus, and it says late lichenoid. So basically they got about as far as we did. The history wasn't helpful, apparently.
Yeah, broad shade. Looks like you kind of got a sparse superficial perivascular infiltrate.
Yep.
Epidermis. Looks like I have a corneal melanoma.
Yeah, exactly. So you looked, you got a little alteration in corneum there and here. And we were going to keep going back.
Focus, it looks like a blue nevus.
Like a blue nevus. Now, are you worried about this one being a blue nevus-like uveal type melanoma? Yes or no, and why?
I don't think so. Looks like it has its own background stroma.
It clearly has its own stroma that's not just the background dermis. So that goes with a blue. If that were absent, then you start thinking, should I get a BAP? Should I get a MIB? Should I look for a possibility of uveal melanoma of skin?
Column with this little basal cell concern. Lots of pigment.
Lots of pigment. And the pigment is in columns.
Right.
And the columns are kind of evenly spaced and similar in width.
It's like a acral.
Yeah, just a little acral nevus. A little bit of buckshot scatter, but that's normal in acral nevi. It's small, well circumscribed. It ends in a nest. The pigment columns are similar in width, evenly spaced. So it just looks like a nevus.
So, superficial and deep interstitial infiltrate. A lot of it crosses roads. Looks like you have thrombus in your vessel.
Lots of thrombi.
So, I know you can see secondary changes in the vessel in the setting of like a profound arthropod, so I'm going to make sure.
Yeah, so, and especially tick for that. The other thing would be something coagulopathic, which is why you get it with a tick bite. And then
interstitial ears.
Yeah.
A lot of mutes and ears.
And
Destruction of the vessel.
which again could be arthropod, or if this is full thickness necrosis with thrombi in the vasculitic group, what would be
Ancas.
ANCA or even septic with all the thrombi. So, you want to know, is this a patient who's super sick, in which case this could be sepsis, or is it someone who had a tick bite? And one of the clues, you got little focal necrosis of the epidermis, and history was tick bite. Let's see how we're doing. We've got time for just a few more.
So this also looks like it falls into the interface box, kind of atrophic epidermis, could be late stage. There's still a little lichenoid band there. Not quite enough orthokeratosis to give a true red, white, blue appearance, but I would consider LSA. And I'd want to check to see if there's a melanocytic proliferation there, because that's kind of
Yeah.
what's concerned.
So, as a clinician, when was the last time you took a piece that big for something lichenoid?
Yeah, not usually. And then there's definitely nest on that side.
Yeah. So what is it?
Regression of melanoma.
Lichenoid regression of melanoma. So you got a burnt out lichenoid area, but the biopsy is broad. We're on sun damaged skin.
So definitely, I'm kind of in the acrosperoma group because they're not blue, they're kind of pink and blue.
Do
We definitely-
acrosporomas usually, is it an anastomosing pattern
Not as much.
with bluish stroma in between?
Oh, it's a mixed tumor.
Mixed tumor, you got it, exactly. So, you went right to benign adnexal sweat gland, which is absolutely correct. But it's anastomosing. I do that all the time. It's anastomosing with bluish hue to the stroma in between. That's a mixed tumor. Okay, Dan. Gout. And this one probably fixed in alcohol. So you actually see the crystals, and sometimes they look brownish.
That part looks like a melanocytic proliferation.
Looks like melanocytic proliferation.
It's pretty evil from this height.
Is it just tips and sides of Reedy, or is it up in the arches?
Oh, it's all up in there, up in the arches.
And
Melanoma.
yeah, exactly. Which is what that is. Big broad. So trabecular pattern, which trabecular or parallel to goes with melanoma, including nevoid.
So you sort of have loss of hair follicles, or at least scar there. I'm worried about like a metastatic Indian filing.
Yep. So Indian filing of cells with molding, so they look boxcar-like, which is usually what?
Breast cancer?
Breast. Correct. Well done.
Is this molluscan? Or a little focus of like epidermolytic hyperkeratosis?
Exactly, that's EHK. So it's an expanded granular layer shot full of holes, and the granules are irregular in shape, and they're both red and blue. So that's EHK. And EHK can be incidental. It can be, we could be at the edge of a solitary epidermolytic acanthoma. If it's a linear stripe on a patient, then it's postzygotic somatic mutation or loss of heterozygosity for congenital ichthyosiform erythroderma. So, you need the clinical to make any sense of it. And that's it. We did 50. Well done.